There we go. All right, so we're going to dive into this presentation. First, I just want to say congratulations. Y'all made it through the conference this week. So I know this is a really small screen, so if you're having trouble seeing, the slides will be available. We have a contractor team that spent hours putting together some really awesome transitions that you might miss. So I would definitely recommend watching. His name's Kenny Colavito. He's your boss. So yeah. So yeah, we're going to dive into the MDPP program today. We're going to use that acronym because we're in government. That's what we do. So first thing we're going to dive into is, what is medical device security and how does the VA, handle, this growing field? I mean, it seems like every day there's a new story in the news about some hospital out there that's getting impacted with ransomware or malware, and so we have to stay vigilant. We'll also touch a little bit on, the Change Healthcare hack that happened back in March. I'm not sure if anyone was affected by that in here, but VA definitely had some mitigations in place. And then we want to, make sure everybody has time for questions. So keep this interactive. So if you have any questions at all, just raise your hand, and we'll answer questions. All right, so just some background on HTM, our vision and mission. To summarize our mission, of all of these things that are listed on the screen here, availability of medical systems is probably our biggest, and especially when it comes to cybersecurity. So making sure our systems are available for our clinicians is extremely important. Availability is also one of the 3 foundational pillars of cybersecurity, so confidentiality, integrity, and availability. So you need to make sure your systems are available, or else your confidentiality and integrity controls don't matter. So that's something that we use on a regular basis. We're talking to our info security partners, like making sure they understand, okay, availability, it's important for both of us. And then our vision. So, obviously we take care of our nation's veterans. We also want to make sure that, clinicians have access to new and upcoming technologies that they need to take care of the veterans. Being in a federal healthcare delivery organization, we run into challenges with being fast or, rolling out innovative technologies. And so in healthcare technology management, that's where we really come and have to play a big part in making sure that it doesn't take 2 years for a clinician to use a piece of medical device that needs to go through some sort of cybersecurity approval. And so that's really where we come in, making sure that we have that vision in mind. Just a little higher level for the VA. So across the enterprise, we have about 171 medical centers. So it's across the entire country. We call them veteran integrated service networks. So you can think of them as just pockets of VA medical centers. Usually 8 or 9 medical centers will make up one VISN. And then we have one central office. And the structure here is unique because it's not an enterprise organization. So not all medical centers report up to the VISNs, and the VISNs don't necessarily report to central office. So it's a different reporting structure there. So there's no direct authority from a central office perspective over the VISNs and sites. So we rely heavily on partnerships and relationships and making sure that the sites and VISNs understand the importance of things that central office wants to roll out, making sure we have collaboration. That's why Meaghen is here, making sure that we're working with them closely and that anything that we do doesn't impact operations in a negative way. So just some other stats about our portfolio. So we have about $10 billion of medical equipment across the country, 900,000 devices, and of those 900,000, we have about 155,000. That number grew about 30,000 devices in the last year alone. So we're seeing an exponential growth for network connected medical devices. And then we have about 2,200 biomedical engineering professionals across the country. So we have biomedical engineers and biomedical engineers support specialists. All right, so the MDPP. So this group has been around since 2005, and it has continued to adapt with the ever-changing cybersecurity landscape. It was this year's AAMI Medcrypt Visionary Award winner. So we're excited to have that. It's comprised of 10 subgroups. So it's comprised of 10 subgroups, which we'll dive into here in a little bit. The 10 are emerging technologies, FISMA containerization, risk management, inventory management, isolation architecture, training and education, which is extremely important, OIG audit, vendor remote access, vulnerability management, and then operations, IT operations. So of all these 10 work groups, they are comprised pretty much entirely of volunteers. So like in the case of Meaghen, this is not her full-time job. She does have other duties that she is responsible for. So everything, I would say 99% of the people that are involved in this work group are volunteers. So it's a really big, it's very important for us. And some of the members are members of multiple. So we try to make sure we don't burn somebody out, but if somebody has interest in medical device security, we'll use them as much as we can. Some of the wins here too. So and again, we'll dive into these in the next couple slides. So actually, I'll probably just skip those and we'll do that then. All right, and I'll turn it over to Meaghen for.
All right, well, so when we're breaking down our medical device protection program, it's helpful to kind of view this and how we've organized in this presentation is approaching cybersecurity as kind of a cradle to grave approach when you're dealing with your medical devices. And kind of the key foundation to this comes with pre-procurement when you're actually taking a look at what devices you're looking at buying and purchasing. The VA uses an enterprise risk assessment model, which allows us to, in the pre-procurement phase, start gathering artifacts and documents when we're looking at purchasing medical systems to make sure that if we can, they're going to meet the cybersecurity requirements that we'd like to get when these devices are rolled out. So with every procurement, the VA 6550 Appendix A form asks the manufacturer for some very basic cybersecurity questions, such as what is your OS and your OS version? What is approved for patching? Can you be automatically patched? Windows updates, do they have to be applied by the vendor? USB ports, can they be disabled or locked? And for the government, very specifically for wireless operations, TIPS Form 140-2 and 140-3 compliance for cybersecurity and wireless operations. So when we're looking at the 6550 Appendix A, that gives us a good baseline for approvals and questions. It's reviewed by biomedical engineers at each site for the procurements, as well as IT and the information security officers. We also ask for the typical forms manufacturer disclosure, the MDS2 statement, and starting now, the SBOM, software bill of materials, that the FDA has helpfully kind of made a nice standardized document that we can obtain from manufacturers moving forward to help get a more accurate software inventory. Because as we know, these devices are not just as simple as they used to be. We're now dealing with also, the vulnerabilities are not just your PAC system. Does your PAC system require use and installation of Adobe? Does it have a Word template that it uses? Vulnerabilities can exist on associated softwares that are required to operate those and installed on those boxes. Now, if a device has been approved and procured within the VA environment, normally we encourage writing in the contracts when those devices are procured. If the device does not have a nationally approved enterprise risk assessment, there are 3 documents that we have the manufacturers and the site collect and work on to be able to submit and have a risk assess. The first is the inventory list, kind of what was discussed here, your listing of your device names, models, operating system, version, software. And again, this can be, you have one device that's being assessed, your ultrasound. Very simple inventory list might just be ultrasound, this is your operating system, this is the version, and here it is. It might be more complex. You're procuring a PAC system, servers, test servers, workstations, backups. And then your next part is your ports and protocols. What is that system communicating on? What is it communicating between? What ports are required to be open between servers and workstations? What ports are required to be open to parts of outside your system? Does it need a remote support connection? Does it need a connection to an NTP server for time, etc.? So capturing all of that information, the external IP connections, the reasons for use. And then finally with your network topology, putting that all together into a diagram that gives kind of the communication picture and the approved deployment model within the VA environment so that you can visually see and everything should cross-match. Your inventory list has your devices, they're all shown on the topology. The boundary is around the topology, and your ports, protocols, and services going between devices within the boundary and then outside the boundaries. All this is put together and then assessed by a team within our IT department, our partners in the specialized cybersecurity devices. And that looks at the inherited risk and impact to the VA. We have further meetings with the vendors to go through your security controls. Be like, all right, we see on your 6550 form that your USB ports can't be disabled. What's the risk of that? Are there any other risks or ways that we can mitigate that? Is your ultrasound kept in a locked area, for example, when it's not actively being used? Okay, your device can't be automatically patched. Vendor, what is your patching process and approval going to look like? Can Biomed apply those patches? Are they required to be applied by the vendor? So trying to get a full picture of, we know that all devices have risk. Now, how can we mitigate those risks? And then how is the standard way in the VA that we're going to say, all right, this is going to be how this device is implemented and how these risks are going to be accepted for use. And once that's done, the device has an approved VA enterprise risk assessment. That means that when a future site wants to deploy or buy for, the device with the same operating system version, they have a reference for how it's deployed. And then they have the approved ERA that says, hey, this device has been purchased by the VA, implemented safely in the VA environment. All right, secondarily, you've got a device, you procured it, it's been risk assessed, getting it on the network in a safe and secure manner. The VA uses VLANs and medical device isolation architecture. Good fences make good neighbors for real life and also for medical devices. So these VLANs are set up, they logically divide a single physical network into multiple virtual networks. This means not only are our medical devices isolated off of our VA IT network, but it's further isolated within the MDIA so that devices cannot easily crosstalk and communicate to other devices they're not supposed to. This helps prevent spread of any infection that should get on there, helps reduce vulnerabilities. You don't necessarily need imaging vendor A to have the same access to the imaging vendor B's systems. If they're kept in nice segmented VLANs, that helps prevent unwanted traffic. Now that traffic is controlled by ACLs, access control lists that provide basic traffic filtering and lanes for that communication to occur. What ports are communications allowed on, and what devices are allowed to talk to one another. And then finally, we're moving towards next generation with firewalls, which provide further active threat monitoring, active data analytics, and advanced capabilities to control some of these parameters. Now, as you probably heard from a wide variety of presentations today, data. Data is important, and knowing what you've got is important, and keeping it maintained. So the asset inventory and the inventory management team works to keep us honest and up to date. As Connor said, we're growing the number of medical devices that are connected to our network. And these are not only just physical assets that are on the network, but also virtual assets. So we have our homegrown network medical device database, NMDD, that provides a comprehensive look at our network connected medical device inventory. There are required fields. We document operating systems. If that device has an approved ERA, what is that? MAC address is the software inventories if available, and it allows us to quickly cross-reference and if you want to see basically what is our count of unsupported operating systems within the VA? What does that look like? How can we capture that, move forward and see what the scope of our problems are? How are we going to address them? How are we going to get up to date? Now, this is accomplished through the implementation of VA medical device nomenclature standards, which is kind of similar and based off of the standard categories provided by ECRI, UMDNS. And then we have naming standards within those medical device nomenclature standards. So we have standard categories and standard models. So we have a large number of medical centers, but with those naming standards, GEB 650 monitors should all be named the same categories, same models across the enterprise. And for network medical device systems, again, we're working on making sure that you've got this version, you've got, the software, it's all in the same category and the same model name for your network medical device systems. So MDNS is establishing your categories and your models for your physical assets and medical devices, and then NSI for your virtual. Now, of course, like any garden, this needs to be maintained, pruned, otherwise it gets overgrown and you're missing things. So we measure this using key performance indicators. We're taking a look in your scanning in NMDD and seeing what % of your VLANs are properly captured within your NMDD inventory. What % of devices are in there? What % of devices are matching the standard categories, standard models, and what % of the devices have sufficient data fields filled out. We have many network tools that allow us to identify where there are gaps on the network. Tools like SMAC, Splunk, we can see, hey, a device popped up on the network in this VLAN. It hasn't been filled out and completed in here. With SMAC, we're actually able to accurately pull in some of that data and fill it out, and then just go in and do a quick compliance conformance verification check. It's accurate, up to date, good to go. Now, knowledge transfer is another topic that's been kind of big here. How are we doing this in a standard fashion? And a great way to do that is checklists. Now, we realize that IT is a field that's only getting more and more complicated. There are processes, rules, and procedures, especially within the government, that change often. The way to keep people up to date, especially as we're onboarding new people, is to be able to guide them through standard operating checklists and processes and procedures. So our HTM operations group works on kind of, again, the cradle to grave way of how to standardly implement, sustain, and decommission devices through these checklists, which are available both on a online format with live links to relevant policies, tools, and references, as well as in printable formats, because some people love to just have paper copies that they can bring with them to be like, hey, I need to decommission or pull a hard drive out of this device. I need to have that. They have areas and fields where people can fill in any ticket numbers, work order numbers, any field notes that they might need to add. And then also, like I said, these are reviewed on a regular basis to make sure they're containing the most up-to-date information. Now, for the implementation checklist, that includes things like how to receive and inventory equipment, and that includes your digital information into NMDD. How do I load a new device into there? How do I make sure that I'm getting the right information there? What fields are required? How do I get that up to date? How to configure a vendor remote connection if that's required? How to make sure that's approved? How to get that done in a safe and secure manner? How to then go and configure your operating system. For the sustainment, we have many processes in with the BA, such as making sure your mobile media is safe and scanned, using our mobile media scanning stations. New technician, you can walk through the checklist. How do I accomplish that? How do I find where this is? How do I scan this device? How do I make sure this is in the scanning log? How am I good to go? How to monitor your ACLs and respond to vulnerabilities and threats. How do I document that then in work orders? And then for decommissioning, how do I pull and sanitize this device? What forms need to get filled out? Who do I give those forms to? How is that all documented? And then if I'm replacing the device, how do I update that in NMDD to make sure that the record is up to date? If I'm totally taking it off the network, decommissioning it, not reusing that IP, how do I then clean up that record and make sure our network medical device database is up to date with what's actually on the network? And then there's got to be wonderful government-specific things in here, which is we have to follow what is called FISMA, the Federal Information Security Management Act. Now, this requires every federal agency to develop, document, and implement an information security program. Pretty broad mission statement, pretty big undertaking. Now, when it comes to this, basically, summation is that all the network devices have to be included in what's called the Enterprise Mission Assurance Support Service, or EMAS. And that includes they have to have deliverables, proof, audits to make sure that they're meeting the right metrics. And this is for inventory tracking and reporting. So those assets are configured to what those different boundaries within the EMAS system. And again, they have to have the documentation to demonstrate that they're compliant with sets of security controls for that authorization to connect. Our current state is we have 136 area medical boundaries. And the goal in what we're moving towards and what the FISMA containerization work group is helping with is moving us to a single enterprise boundary. And since we love our acronyms, it's called MD Light, which stands for Medical Device Legacy Information Technology Equipment. It's MD Light, that's a lot catchier to remember. So the goal is that from 136 area medical boundaries, we'll instead be moving to one big happy family, which will offer some advantages such as streamlining security processes, improving our governance, and then probably most importantly for the field, allowing us to use enterprise level documentation for something called a Plan of Action and Milestones, or POAM, which is basically if there's a security aspect of a device or control that isn't compliant, isn't met. Let's say there's an out-of-date operating system, there's something that needs to be corrected or fixed, rather than having 136 versions of that document, one for every single area medical boundary, there can be one opened up for the enterprise saying, hey, we know that this is an issue with this, we know the risk, we've got it documented, and here's our plan to address it. So I'll turn it back over to Connor, and we'll go to the next set of groups.
So before I go to the next one, we're halfway through the subgroups. Does anybody have any questions I can answer? Hank, how many network connected medical devices do we have?
Many.
Okay, yeah, there you go.
Many.
More every day.
Yeah. All right, so jumping now to OIG audit. So this is very closely related to the FISMA containerization work group. Just some more background on how VA is kind of set up. It's a unique organization. So the Veterans Health Administration is actually a separate organization to our Office of Information Technology. So we work closely with them, and now I'm going to throw in the HIPAA security rule and the HIPAA law. OIT is actually our business associate. We are the covered entity. So they are providing our IT services for VHA. And so OIG and FISMA are IT policy. We, from a VHA perspective, we have joint commission, we have the security rule, we have, those lines, environment of care. OIT doesn't care about that. But because we are a federally, federal healthcare delivery organization, we do fall under FISMA. So this is like trying to fit a square peg in a round hole a lot of times, especially when it comes to FISMA and OIG audits. So we are on the hook to, to help our Office of Information Security and Office of Information Technology partners with their annual OIG audits. So we will, every year OIG selects, I think it's like 15 sites at random where they will show up and they will perform an audit. They'll be there for multiple weeks and they will look at medical devices. And so we help prepare those facilities that are selected. They have 15 artifacts, we call them artifacts, but they're 15 artifacts that they have to gather prior to the OIG audit visit so that those are ready, when the OIG auditors sit down. So the first, we keep a memo of media sanitization personnel. So who are those people that are authorized to pull out a hard drive and sanitize it, punch a hole through the hard drive? Example 2 is an example of an enterprise risk analysis. So that's what Meaghen talked about a little earlier. We need the medical equipment management plan. So I think everybody's familiar with what that is. We know we're going to take a couple corrective maintenance and preventative maintenance records from a couple pieces of medical devices just to kind of show how our change management process works. Audit logs are important, and this I know it continues to be a challenge, but pulling audit logs from medical devices. Access to any sensitive room, so server room, who has access to those rooms, who has access to your telecom closets. We're not letting anybody walk in there when they want to. Vendor visitor logs, so who's been on your facility and who's performed work. We have scanning stations, so anytime a vendor brings in a USB to perform maintenance on a system, we will scan that USB, make sure there's no Trojans on there, any other virus that we need to be aware of. We also want to take a photo of that scanning station, make sure it's set up and configured appropriately. Remediation of all of our medical device vulnerabilities. So we do have a vulnerability management program, one of our upcoming subgroups we'll dive into a little more. The network medical device inventory. So we have a KPI to maintain 100% compliance. So once you plug a medical device in the network, if it falls within a medical device VLAN, you have 1 day to record it in our NMDD. If you don't, then you'll drop below 100%. So it's a good way to keep people accountable. We plug something in, make sure you record that. ACL remediations. So, we do update our medical device isolation architecture rule set as the threat landscape changes. So if there have been older ACLs that were rolled out, 3, 4, 5 years ago, they might have rules that were once permitted and now are not. So we need to make sure that we're remediating those high and critical ACL vulnerabilities. And so we'll provide those. And then remote access. So we establish, and there's a subgroup for this too, but we establish site-to-site connections with any of our medical device manufacturers that require a service agreement or direct connection to their systems. This is done via NAT, network address translation, and port address translation, so NAT and PAT configurations on the actual Cisco routers. And so, we want to make sure that we're documenting those. Those are important, especially with, like we mentioned, the Change Healthcare issue, knowing where, we have these remote connections. So vulnerability management. So this is a subgroup. I mean, it really does comprise a lot more. We have a very robust vulnerability management program ranging from the risk assessment to our medical device isolation architecture. You know, there's a lot. You know, right now we're going through a new you know, CMMS upgrade, and that plays a vital role in any, you know, cybersecurity, successful cybersecurity program. The technical configurations, so the checklist that we talked about. So some more specific vulnerability management. We have an in-house tool. It's called SMAC. It's actually the initials of the individuals that created this, but Order, for those of you that know Order, they actually took this code and have built it into their platform. So if you're buying Order, you're actually getting SMAC. And so essentially this is a way to automate our inventories. So you know, you download, it's an agentless based system. It's Windows tools built in, and it will automatically upload and update that network medical device database. So that is you know, pretty cool. And then the patch repository. So not all medical devices can handle automatic patching. So for those vendors that handle manual patching or release a patch schedule on a monthly or every other month basis, we have lines of communication with them. We'll build which patches they can apply, and so, you know, BESs and BMEs can go to that site and have a quick view of what they can patch and what they can't. And then vulnerability remediation. So right now we're actually kind of improving this process right now, but we run a passive vulnerability scan across our enterprise. A handful of devices are actively credentialed scanned, and so every facility will receive a vulnerability report with their vulnerabilities. They have 30 days to remediate those vulnerabilities and then send that report back in. So that's all performed via a Nessus vulnerability scanner. And it's done once a month. So vendor remote access. So any vendor that comes in and says, hey, we need to connect to your systems, it's an immediate like, okay, this is going to take a little bit longer to implement because we need to make sure that we have this, you know, this documented and done correctly. So the first step is we develop a memorandum of understanding for that interconnected service agreement. So we call them MOU ISAs. But essentially, we need to know exactly, okay, where are you coming in from? Like, what does your infrastructure look like? What encryption do you have on your systems? What audit log mechanisms do you have on your end of the tunnel? And we need to build that document out, making sure we know, okay, what PHI elements are being sent, if any? What are you using the tunnel for? And so that is done over the course of a few months. Once that's signed and documented, we will work with our networking operations center and our external firewall teams to modify the firewalls for those NAT and PAT connections. So in the the example of Change Healthcare, you know, we did have a few sites out there that are using Change Healthcare packs for the radiology. And when we found out that Change Healthcare had been compromised, you know, we immediately cut the tunnel. We knew exactly. I mean, it really happened almost immediately. Once we found out that Change was compromised, that tunnel went down immediately. And so that did help prevent, you know, any sort of propagation across the tunnel. Like, I mean, I think we were lucky, and so, you know, we are, you know, making sure we continue to do this, and we're actually rolling out a new incident response testing with some of our big vendors like Philips, Siemens, GE. On an annual basis, we're going to be doing tabletops with them and running through different threat scenarios. So, okay, what happens if GE has an insider threat and they decide to, you know, before they're fired, log into our servers and turn it off? Okay, so how do we know who did that, when they did that, when they accessed the tunnel? What do we do? Things along those lines. And then we also have client to site. So if a vendor doesn't want to go through the whole process of creating a site to site, we will work with them to get VA accounts with elevated privileges so that they can log in via, we have a Citrix Access Gateway or Azure Virtual Desktop. They'll come in via that way and then use their accounts to log in. So that, you know, that is a preferred method because that accountability, that audit logging is done all through VA's built-in network security. But some vendors like GE and Philips have hundreds of service personnel. It's a revolving door, so we don't always know. You know, it takes time to get people accounts. We don't have the bandwidth now to continue to get people accounts. Training and education. So this is a pretty cool thing that we do within the VA, recognizing the change in, you know, that networking is now becoming bigger and bigger need for BESs and BMETs and BMEs to understand We have a team that builds new courses. So we have, I think it's 10 courses that we have, ranging from, so I'll just jump through. We have an intro to cybersecurity course, basic networking. So this is comparable to CompTIA Network Plus. We have Windows Server. So this is comparable to CompTIA Server Plus. Introduction to operating systems and SQL, intermediate networking. This is more aligned with your Cisco CCNA and routing and switching. That's kind of the stuff that's taught there. Introduction to virtual machines, so VMware and Nutanix. Principles of HTM cybersecurity. So we try to, and this isn't just specific to this course, but we try to make sure we're building in VA specific policy in these courses so that we can relate how you're using these in the real world. Firewall essentials, so this is the Palo Alto firewall, how we can build rule sets. DICOM fundamentals, so we actually have Laurel Bridge, and they have a test environment with Compass routers. People can take the class, configure their modalities, learn how to use a Compass router for routing DICOM images, and then introduction to HL7. So building those HL7 links, understanding what is ORU, what is ORM, ADT, those kinds of things. We also provide vouchers. So after they take the class, if they want to go get CompTIA Net Plus certified, they can, we have those available. All right, and then emerging technologies. So we try to stay on top of things, especially in medical device cybersecurity. We trying to make sure that we are talking to our industry partners. We have regular recurring meetings with Mayo Clinic. We regularly meet with Cleveland Clinic. We regularly meet with the FDA and NIST and their medical device cybersecurity teams. We also talk to OMB. Well, we're actually going to be down in DC in 2 weeks to talk a little bit about the HIPAA and the FISMA challenges I just mentioned a little bit earlier on a panel with the FDA and NIST. So we try to make sure that we're asking them, okay, where are you going, so that we can stay ahead of the curve. The VA right now is in the final stages of finalizing a MOU with the FDA, Division of Medical Device Cybersecurity, so that they'll be able to share confidential data with VA. So that's going to give us a leg up, in terms of where they're going to be going. We'll be able to kind of stay lockstep with them. One of the biggest needs that we need in the VA is replacing that network medical device database. So we have looked at some of these network discovery tools like Order, Medigate, Simile, some of these, these tools that are going to do that automatically, really take our program to the next level. That is something that this work group has really helped lead and build, contracting documents and those requirements, and making sure we have that ready to go if funding is obtained. And then we're doing a lot of really cool things with the SimLearn lab. So VA has a SimLearn down in Orlando. It's used for nurses. They can fly down, they can get trained. But we're actually going to be building that out for medical devices. So we're installing medical devices down there. It's going to be more of a sandbox environment. So we'll be able to do things like penetration testing, configuration management testing. We have, one of the things we're testing now is SCCM for configuration management and baseline compliance. So, making sure that those devices that are rolled out with ERA configuration are configured correctly per that ERA configuration. And then we're also working, with vendors that want to, if they want to become PIV compliant or two-factor authentication enabled, and they want to test that in a VA environment, they'll be able to install their servers down there, and they can play around with, do whatever they need to do to get that to work. So, in summary, we really want to make sure from a MDPP perspective that we are working very closely with the field. Anything that we do at an enterprise level through the work group, we want to make sure that the field agrees with or is fully understood and engaged prior to rolling it out. Do not like to be caught off guard. And so that's a big thing that we try to make sure. We also are trying to build those relationships. So like I mentioned, the external partners, we're trying to build them internally as well with our OIT and OIS counterparts. It's a little bit more tricky than some of the more fun conversations we have with external partners, but we are continuing to do that as best as we can. And then we want to continue to recruit and retain. So offering these, the cybersecurity trainings and offering the ability to join some of these work groups. The VA has many, many work groups. This is just one, but offering those, those opportunities to people to help them elevate their careers is something important to us. So that was all I had. I think we got, what, 10 minutes for